said, is the third common cause of blindness in South Africa. Number one, in cataracts, which is reversible, and number two, glaucoma, which is reversible, but is manageable, we can control it. And I think it's sort of like preventable, but once it sets in and sort of advanced, then we know the outcome is not good. And so basically, we know subordination is the most common ocular complication, and it's a cycle. And how it does all these things is because it works on the small vessels with two mechanisms. Your microangiopathy. Basically, your vessels are very weak, so they start to leak. They leak fluid or they leak water into the essential part of the vision of your macula, which helps you with fine vision, and also the optic nerve, which transmits the impulse to the occiput, so for your vision. So, and then the other thing is with your microvascular vision, which will be as a result of prolonged hypoglycemia and also associated cholesterol levels that could be from atherosclerosis. So those processes of vision could lead to the retina vessels itself trying to take some chance. So for the blood vessels to keep flowing. And what happens is that if there's prolonged vision, now the VEGF drive goes up. Now you start seeing a lot of abnormal vessels growing around the nerve and also elsewhere on the bodies. And in terms of prevalence, we know that it's more common in type 1 diabetes, and it's threatening in up to 10 patients, like 10% of the patients. But we know that these data are not from local. What we see in our ground here in St. John's and also here in our disadvantaged population is far more than this 10%. Most of the people that come to the hospital, maybe it could be delayed referrals or delayed presentation to the clinic or so forth, but patients, they come already at far end of the stay. So in terms of the risk factors, the most important one is the duration of diabetes. So we found that patients who were diagnosed with diabetes before the age of 30, 50% of them by 10 years would go diabetic retinopathy. And by 30 years, 90% of them they got diabetic retinopathy. And the other thing is that around 5% of these patients, they do present to the hospital at first presentation already with diabetic retinopathy. And the reasons could go as many as, by the time someone goes to the doctor is when they can't see. So the question is that how long has there been diabetes, like diabetes happening in the body? And then poor control, like the previous speaker was saying, the PDS and the DCCT studies, they refer that patients who are not controlled, obviously they're going to progress faster to develop diabetic retinopathy. Pregnancy, pregnancy, there's a lot of physiological changes that very sensitive tiny vessels are already strained. So there's a lot of fluid imbalances. If they were not controlled before they fell pregnant, things get worse. If there's diabetic already, then they tend to progress. But however, what was found was that patients who would have just had a normal swelling of the macula or diabetic macula during pregnancy, the moment they deliver the baby, postpartum, they tend to regress. There's a lot of fluid going away. Then even that fluid of the macula tend to regress. And patients with hypertension, we know hypertension is a risk factor of everything because it works on the vessels, which are already compromised with diabetes. And nephropathy, like we say, if your kidneys are not functioning, the rest of the body can't function. And your other factors, it's your bad lipids, your cholesterol, your smoking habits, because they tend to affect the vessels. And obesity and anemia, and also cataract surgery, because you can imagine someone has got uncontrolled diabetes, and then you go and you do cataract operation. Remember, now you are inducing a lot of inflammation in the eye. So ideally, we want to control the patient. We want to have a certain number that we say if it goes beyond. Normally, if it comes with sugars of more than 50, then we don't want to touch those eyes. We want to control the inflammation, because they also at increased risk of infection and endophthalmitis. So the pathogenesis just tied it up in a nutshell. And then symptoms, most of the patients, they are asymptomatic. They don't know what's happening. Optoms tell that, I've got this patient who comes, they've got this unstable refraction. You do them, they seem to be like pluses. All of them now they are like minuses. You're not really sure what's happening with this patient. This is simply because a lot of sugar in the eyes. That too much sugar into the eye in simple terms. There's a lot of conversion into sorbitol. Sorbitol accumulates in the eye swells, the eye lens swells. So as the eye lens swells, the cornea also swells, then the refractive index changes. And then when this patient is automatically controlled, like say, you were on the 20s, now you're all of the 6. So that transient improvement of sugar, it causes a lot of water to move out of the lens. Then now the shift would be like, now they can't see, and from myopic shift, now they go to a hyperopic shift. So that's why, when you test them, they've got this unstable unstable refraction. They're going to have blurriness of vision from swelling of the lens, from swelling of the cornea. They tend to have floaters, they tend to have IC shadows, usually because if they've got new vessels, then they tend to bleed into the vitreous. And then they will have distortion of vision, and they'll tell you that they've got poor one-eye vision. Obviously, all the structures now are affected from the back on the retina. And then they tend to have partial and total loss of vision. Partially, if they've got vitreous that is settling down, then they can still see properly. But once it comes to the visual axis way, then the vision goes away. So in terms of the clinical signs, you can see the AD, they will have the cotton wool spore, they will have lipids leaking into the macula, they will have this exudation on the macula, which when they have this and they decrease fovea because this patient has got a diabetic macular edema, and then they tend to have the bleeding of some sort, and then they will have these small patches of dots of blood from the capillaries, which we call the macular aneurysm. Usually most patients when they present, they tend to come with only macular aneurysm. Then that helps also when you are classifying these patients. And then as the disease advances, then you're going to start seeing that now there are new vessels that are developing. They've got new vessels that are developing elsewhere, and then they form these bands. Now because of the new vessels that are developing, the layers of the retina they start to separate, and then you're gonna see what we call tractional detachment going forth there. And then they can also have what we call EMA, which is the intra-retinal macular anomalies. So when the vessel is sort of like blocked, now the retina is trying to survive. So they form this abnormal vessel that typically happens between a venule and an arteriole. They don't go beyond the bridge. So if they go beyond, then you know that this is not an EMA, it's a new vessels elsewhere on the fact that you need to go laser. So if you see an EMA, then as initially you don't have to go laser because now the eye is trying to survive. If you go laser, the eye is gonna die anyway. So in the past, they were classifying them according to background, proliferative diabetic retinopathy. But nowadays we use the ETDR, which is early treatment diabetic retinopathy study. So we're going to classify the patient according to their clinical presentation. When we do the fundus photos, you have your group of your non-proliferative diabetic retinopathy and the proliferative diabetic retinopathy. Of importance, I'm not going to go through all of them. So you've got non-diabetic retinopathy, very mild. The important one is your very severe non-proliferative one. So this one, they will have 2 or more of the above pattern of the 2 in 1. So they will have a lot of hemorrhages on the, they will have a lot of hemorrhages on the fundus, and they will have those shunts that are trying to make the retina to survive the EMA, and then they will have significant venous bleeding where you see it in 2 or more patterns. So when you see this patient in the clinic, as long as the patient does not have lupus that you can see, you don't need to laser the patient, but you need to know if this patient is a high risk, then you need to follow up this patient very closely. Instead of sending them away for 3 months, rather send them give them 4 weeks, review them 4 weeks until you see new vessels that are developing, then you can give the patient laser. And then with your proliferative diabetic retinopathy, then here there's new vessels that are developing on the disc, there's new vessels that are developing also on the fundus. It goes again with 3 classes. You have your mild to moderate, you've got your high risk PDR, and you've got your advanced diabetic retinopathy. So these ones, they need treatment. So for example, your advanced one, this is the one that will have vitreous hemorrhage. The pressures are very high, like 60s. They've got neovascular glaucoma. So they've developed new vessels also on the iris, and also on the blocking the drainage of aqueous fluid out of the eye. And then you also have your tractional retraction. When you look at the back, they've got membranes pulling at the back. So these patients, the thing that causes loss of vision in diabetic patients, so it's macular edema, is what I've seen. You can see the exudation around the macula and the decreased foveal region. So when you do the OCT, you will see you will have the cystic spaces and also some which represent fluid accumulation in the layers of the macula. So these ones, we call them macular edema, and then you're going to have those that will come with swollen discs and also some changes also on the macula. So those ones have a diabetic papillopathy. But otherwise, before you label the patient to be diabetic papillopathy, you need to have also ruled out all other possible causes of swollen disc, because you can just say the patient with diabetic papillopathy and the patient is having a big tumor in the brain that could be life-threatening. So the other ones is your vitreous hemorrhage, is your tractional retraction that I was saying. So if they are pulling on the macula, the patient is going to lose vision. And then the neovascular glaucoma, where you're going to see a lot of vessels on the iris and also in the endoscope. So in terms of management, these patients use basic one, like you go to a general control, the education about controlling of diabetes, and then also the diabetic control should be optimized, and then also the other systemic factors should also be attended to. The patients with hypertension, anemia, they should be attended to, and then also you can also do the fenofibrate for your cholesterol. Most people are advocating to just keep most of their patients, with the high risk, to just keep them on these cholesterol medications for life. And then now we just recently know that diabetes can also lead to mental health. We should edit that. This should go to third floor. And then if the patient has got diabetic macular edema, we do have options for these patients. We give them anti-VEGF, which is commonly in public. We've got bevacizumab, which is Avastin, and then when you go into private, you get all the lights of the wishes, then you can just pick up whichever is available in private, and then you've got your corticosteroids, your transdermal, and then you also get, so these ones, as you can see on that image, you inject directly into the vitreous. The laser, in the past, we don't really do the laser on the vascular entities, so the anti-VEGF is like the gold standard at the moment. And then PPV, we only do the operation if the edema is associated with something pulling, or if there's like some tractional pulling on the macula, then you just want to go relieve those one before you inject. Because if you go inject when the skin's pulling, they're gonna become more or worse. And then with your new vessels on the disc or new vessels elsewhere on the body, you wanna give the patient a laser. Like those are the laser marks. You wanna give as much as you can. You wanna laser the fast so that those vessels can regress and the patient can preserve their vision. And then there are instances that you can also give the patient anti-VEGF, like your ranibizumab, especially if the patient has got new vessels developing and also they've got a solid macula. So you can give anti-VEGF, and then it can attend both issues. It can attend it can cause the regression of the vessels and also address the swelling of the macula. However, we do have other instances that you can also do anti-VEGF and also do laser at the same time. But the other issue, most people don't like to do the laser, because laser can also worsen the swelling of the macula. So you just want to choose what you're dealing with in your patient. And then with your advanced diabetic retinopathy, if the patient has got high pressures, those ones you just give them anti-glaucoma medication, the topical and the tablets, just for temporary. It's not like a treatment. You wanna try to build the pressures lower than when you're thinking of the alternative. The best thing that they need is they need a trabeculectomy, so that we shut the fluid out, because completely the drainage is blocked. And then you've got patients with vitreous hemorrhage that is not going away. If someone comes with vitreous hemorrhage, ideally if they don't have contraindication to inject like bands or retinal detachment, you can give them Avastin. You'll be surprised by the next 5 days it has resolved. The patient has got 6 vision. And but important that after that, when you have good clear view, you need to go put a lot of laser on the bundles. And then if the patient has got transient retinal detachment that is threatening the macula, we also want to go to the PPV to release those structures, because the more is pulling, the macular swells and then the patient loses the fine vision. And if the patient has got combined transient retinal detachment and dermatogenous, where there's a tear, you also need to go to operation. Or if the patient is bleeding right in front of the macula, because that bleed obviously is going to disturb the light from getting to the fovea. So you also want to go to the operation and remove that blood. And then the other thing is that if the patient is having like your cataracts, you can also take the patient to do combined procedure. You can put the cataract and also do the posterior work of the patient. I think in a nutshell, that's about it. So the important thing is that all the medication needs to be screened. Thanks to our because I've seen most of the optom they've got a fundus cameras and they've got positives, which is very amazing. By the time they come to us, they already have everything. They will just do the management. So importantly, refer all the patients to be seen by ophthalmologists and also optom. And always they go back to the GP for optimization of the sugar, because some of us will checked out. Yes.